Third time will be the charm. Okay. Hello and welcome to today's webinar for mental health professionals, medical marijuana laws and evidence for harmful beneficial effects in depression and anxiety disorders, featuring Dr. Kevin Sebat and Dr. Rajiv Radhakrishnan. I would like to introduce Dr. Sebat and Radhakrishnan. Dr. Sebat is an author, consultant, former advisor to 3 U.S. presidential administrations, assistant professor, and serves as the president and CEO of Smart Approaches to Marijuana, which he founded with former Congressman Patrick Kennedy in 2013. He has studied, researched, written about, and implemented drug policy for almost 20 years. Dr. Rajiv Radhakrishnan is an assistant professor of psychiatry at Yale University School of Medicine. He is board certified in psychiatry and addiction medicine. As a physician scientist with a research interest in examining the effects of cannabinoids, he has conducted laboratory studies using THC and is currently examining the effects of cannabidiol on brain microglia activation using PET imaging in an NIH-funded study. There will now be a brief moment of silence while I pass the presenter role to our presenters.
Great. Looks like we're ready to go, I think. We want to thank the ADAA for having us on this webinar today, and my colleague Rajiv as well, Yale University Medical School, and really all of you here to listen to, I think, of a really important webinar. I'm excited to see and to hear what Rajiv has to say. He's an eminent expert, and it's an honor to share a platform with him and really with all of you who are the experts in the field working every day on a very, very difficult issue, and an issue that has been hidden for so long, an issue that is not one that many people want to confront, but is a major issue with anxiety and depression. And I think an issue that is very, very prescient given the issues surrounding marijuana today, this massive change in attitudes regarding marijuana that seems to have come like a tidal wave in terms of the speed. I want to specifically thank ADAA and its founder, who founded it the year after I was born, if you can believe it, and that's Robert DuPont. Dr. DuPont is a living legend in my mind and so many other minds. I think our field, and when I say our field, I mean mental health and addiction, are so lucky to have such an eminent thinker, such a practical thinker, such a caring thinker, and that care that he brings is something that he's brought to his children and his wife, who have been all very involved in these issues for so long. And I count Bob as one of my very closest friends, and someone that I look to for constant counsel, and I'm sure many of you do as well. Well, I'm very excited to start this webinar. I wanted to first talk about disclosures. I don't have any, so that's easy. I don't get any funding from whether it's the pharmaceutical companies or any other industries to do the work that I'm doing. My background as a doctorate has been in the issue mainly of substance abuse, and in the last 10 years with a specific focus on marijuana and what's happening. And so what I'm hoping for today is to talk and really frame the policy and environmental atmosphere that all of this discussion is going on. And then I'm going to pass it on to Rajiv to talk much more about the clinical and about a lot of the studies that we're seeing, which are very, very exciting in this area. But I think we're marching forward very, very quickly, too quickly in this country. The policy is way ahead of where the research is in many states, and we're doing it in the absence of evidence, in the absence of really any public awareness, and in the absence of the understanding of implications. You know, we're seeing so much out there, frankly, funded by the marijuana industry, promoting the use of high potency, raw grade THC for anxiety and depression. And that really worries me, given the research we're seeing. In fact, there's so much new research coming out, we can't even keep up. When these slides were completed about 2 days ago, which I thought was pretty recent. Even since then, we've seen studies, a study coming out yesterday about the weekly use among adolescent boys of marijuana and how the weekly use increases significantly the risk of anxiety and depression. That just came out 2 days ago. So it's very actually hard to keep up. But the issue is we still need more research, and we still need to look at the marijuana more comprehensively, because there's so much about it we don't know, as well as things we do know that I think are not great. I think we're repeating history in many ways. We saw for 100 years the tobacco industry promote their product as medicine and then as recreation for adults, all the while promoting this to young people. I think we're seeing that with the e-cigarette industry now. We're seeing that with the marijuana industry. One of my favorite posters is Dr. Batty's asthma cigarettes. We're seeing this now for marijuana with anxiety and depression. We're seeing this industry copy what the tobacco industry did 100 years ago, because frankly, it was a very good playbook. Tobacco kills more people than any substance known to man. And it does so not because one cigarette is more harmful than a vial of heroin. It does so because of the use, the normalization, the prevalence. That is why it is so deadly. And that's what I worry about. I think too often we have a false dichotomy with regards to marijuana, that we either want to or have to legalize it and promote it and have a tobacco style legalization, or we want to have a war on drugs and stigmatize people and throw them in prison. And I think we have to really think about this as a false dichotomy, that's actually not our only two choices. And so we at SAM, working with science advisors from around the country, are trying to translate science into the language that people can understand. So if you want to learn more about outcomes related to legalization or things like that, please go to learnaboutsam.org and you can learn a lot more, and it's all free. We collaborate with multiple medical associations. Today's is another example of a collaboration, which we're happy about. But I think that there are three separate issues that often get conflated, and we need to be very, very clear about that. And even within these three issues I identify here, there are varying shades. And so we still have to be even clearer about it. The first bucket I would say is about criminalization or decriminalization for the individual users of marijuana, or really any drug, for non-medical purposes. The second is the legitimate medical use of usually the components of marijuana. We throw the term medical marijuana around a lot. What is medical marijuana? Well, there's really no such thing as just medical marijuana, but there is such thing as, cannabidiol oil in the form of Epidiolex, which I'm going to talk about later, or, different ratios that are out there that other countries have approved, like nabiximols in other countries. So we do have legitimate medicinal use of the compounds derived from marijuana. But that is very different than smoking a joint if your back hurts. So I think that there are real differences that we need to understand. And then also, of course, this is very different than the legalization of marijuana. We have to understand that as well. We're not talking about the old joints anymore. We're talking with regards to THC about edibles, candies, cookies, these kinds of things. Very different than the Woodstock weed. We're talking 98, 99% THC, the waxes, the oils that are out there. These are not being studied really at all. We don't know anything about them. The studies we have are on much lower THC. So that is a really important caveat to understand, is even the studies that are showing the negative effects, they're done on THC that frankly is not even that popular anymore. So we have to understand again, within the bucket, what we're talking about can be very, very different. Let's talk about medical marijuana, obviously, now, and what that movement has been. Colorado, we hear about a lot for legalization. Well, they didn't legalize marijuana overnight. We have to understand that the activism with regards to medical marijuana actually didn't start in scientific circles. It started in activist circles. It started as a way to promote marijuana with event sponsorships, coupons, and these kinds of things. And we have to realize that the people behind it are Wall Street players. They're major investors. These are not the old hippies from Woodstock. They're very smart people, and they were very smart in what they're doing. And my worry, and I'm not going to get into a lot of details here, but my worry is that because THC affects all of these different receptors in the brain and throughout the body, that we are essentially commercializing, as Dr. DuPont actually would say, recreational intoxication. And we have to think about what that means. The industry today, the marijuana industry, The same industry that promotes marijuana for anxiety and depression, they're promoting kid-friendly items, very potent items, very aggressive marketing with free samples and billboards and big tobacco tactics. We're finding many, many contaminants. So this idea of regulation actually is not really coming to fruition. And frankly, if there is regulation, it's being fought by the lobbyists, very, very powerful lobbyists, donating to candidates. And now we have Colorado as the #1 state in the country for first-time marijuana use among youth. We have rampant commercialization, drug dealers haven't gone away. We have a thriving underground market, and all the things we've tried to do, cap THC levels, limit pot shops and medical marijuana stores, all of these kinds of things have actually been thwarted by a special interest. And I say all that because we have to remember how this happened, and how this happened was through the medicinal use of marijuana, which doesn't mean that there isn't legitimate medicinal use of compounds. There are. Rajiv's going to talk about, I'm going to talk about that a little bit, but there's a lot of illegitimate. And if you look at where it came from, the old stereotype was the old, young guy smoking a joint. The new image has been changed to really, your grandmother who needs something, who needs marijuana to survive. And this was a very deliberate tactic. We have to remember. Legalization advocates admitted 41 years ago, that medical marijuana is a pretext for legalization. The head of NORML, which is a big pro-marijuana group, said, we will use medical marijuana as a red herring to give marijuana a good name. And so they advocated it by popular vote instead of by FDA regulation. And that worries me, because I don't think any medicine should be voted on. I don't think any medicine is a popularity contest. I think medicine should go through science. And so if you ask someone, is marijuana medicine, it really depends on how you look at the question. It's not in terms of smoked or ingested raw marijuana. It's not. If you define medicine as a specific product approved by FDA, that hasn't happened. But there are marijuana-based pills and other oils available that have been approved. And then I think the big question is, maybe we're doing additional research into the medical properties of marijuana-derived compounds, and we need to do more research. And we at SAM think there needs to be better research done. There needs to be more research done, but we don't need to legalize to do research, because right now the industry is way ahead of the scientists. I mean, let me tell you, if our colleagues, at Yale could get their hands on all of these to study legally, boy, it would look very different than what it is now. The industry is totally ahead of where the science is. And when you look at policy, you have to remember that not all US states treat marijuana the same. Some have decriminalized, some have legalized, some have medicalized, some have done nothing. Actually, medical marijuana programs vary wildly throughout the state. And I actually think that's problematic, because if I told you that, programs for, prescribing hydromorphone, which is obviously a very powerful opioid, was different in California versus Nevada versus Massachusetts, I think that would be problematic. I think we need to have the same standards, but for marijuana we have wildly different standards. What is the goal of medical marijuana? Again, it depends on who you ask. It depends on where you go. We know from research that the average user isn't really that sick. The average user is a 32-year-old white male, no history of life-threatening disease. They don't have fourth-stage cancer. But they have a history of drug abuse. Whereas when you actually look at who's using medical marijuana cards, fewer than 5% have some of this extreme problems. I will say that anxiety is a growing category, and that worries me because of the research around anxiety. Many of you might be thinking about, what about Schedule 1? Does that prevent us from actually researching it? It actually doesn't. It just simply means it doesn't have medical use. You can research Schedule 1 drugs. It's done every day. Is it easy to do? No. Should it be easier? Absolutely. Should the scheduling be less confusing? Absolutely. I'm not going to go into those details, but we can reform and should reform the scheduling system. But that doesn't mean we need to legalize in order to research. We wouldn't legalize heroin in order to research it. We wouldn't legalize cocaine in order to research it. We would make research easier to do, and that's what we should do. There are some approved cannabinoid products. I'm not going to go through all of them here, but there are FDA approved products deriving from marijuana, and we should absolutely use those when we need to, especially for some of this childhood epilepsy we're hearing a lot about, and the different kinds of syndromes that are out there. Cannabidiol, CBD, which is a non-intoxicating form, Rajiv's going to talk about more, we actually do think could be used for a lot of this. And there's a lot of other CBD in development and other things that are happening. The FDA isn't very pleased about what's out there on the kind of CBD market that you see at the gas station and the alternative stores. They're seeing a lot of contamination. They're seeing the fact that CBD products don't even have CBD in them. That is really buyer beware. The University of Colorado reviewed dispensaries, or what I would call artisanal CBD, non-approved, and with 58 children, and found a lot of problems in it because there were contaminants, versus when you actually looked at something like Napodial-X, which did decrease seizure frequency. I am concerned that medical marijuana and recreational marijuana laws do not effectively prevent use among minors. There is a growing number of studies out there showing an increase, especially in cannabis use disorder in legalized states and medical states, and that's something we need to be looking at. We need a long-term solution to expand authorized research. As I was saying earlier, I think that's very, very important. And really, you might be thinking, well, isn't it better than opioids? Why are we even talking about marijuana given the opioid epidemic? We've seen many of these billboards around that say that if you legalize marijuana, you have fewer deaths. The marijuana industry sees a very big business opportunity. And I think we all need to not be naive about what this is really about and where the industry is. We've seen a lot of wild claims that marijuana helps with all of these things. The reality is, they suffer from ecological fallacies. They don't look for other explainers. And when you do update the studies, like Stanford did a few months ago, actually it's often reversed and you cannot find any relationship. So we need to worry about that. I think we need to worry about, I'm not going to call it gateway because I think that has a lot of terms that we're not really comfortable with. But I am worried about the studies out there showing the increases in priming the brain for other drugs when you use marijuana. And I am very concerned about people with anxiety and depression using those when we're seeing study after study showing twice as likely to be at risk for opioid addiction if you start marijuana before you're 17. In utero increases. And the National Academy of Sciences, which I urge you all to look at, we're seeing marijuana use is likely to increase the risk of developing dependence other than cannabis use disorder. We're seeing in mental health, the higher the use, the greater the risk of schizophrenia and other psychoses. We're seeing a lot of other issues there that I'm concerned with. I'm concerned with the fact that we're seeing increased opioid deaths even in Colorado. So we're not seeing the results we thought we were going to see. And I want to leave you with a final word by Dr. Nora Volkow. She says, repeated marijuana use during adolescence may result in long-lasting changes in brain function that can jeopardize educational, professional, and social achievements. And I'll stop right there. I mean, that really is the issue with regards to anxiety and depression that we're seeing, is that these are long-lasting changes. And with so much we don't know about what's out there, we just have to be cautious. Because, as Dr. Volkow continues, the effects of a drug, legal or illegal, are determined not only by its pharmacologic properties, but also by its availability and social acceptability. In this respect, legal drugs offer a sobering perspective, accounting for the greatest burden of disease, not because they are more dangerous than illegal drugs. Like I said earlier, a cigarette on its own is not more dangerous than a vial of heroin, but it is more dangerous on a macro level and causes more harm on a macro level. Why? Because their legal status allows for more widespread exposure. So my whole thing is, let's slow this train down. Let's do the research. The industry is making wild claims. Frankly, if any pharmaceutical product made the claims about anxiety and depression that marijuana folks are making, they would be in prison right now. Ironically, the marijuana folks are not in prison. When I say the folks, I mean the CEOs of these multi-million-dollar companies. Because it's still illegal on the federal level. So it's a little bit of this see no evil, hear no evil approach by the federal government that I think we really need to understand. You can learn a lot more at our website, which is learnaboutsam.org. You can email me. I get these emails, info@learnaboutsam.org. But I wanted to frame where we are, why we're seeing the acceptance. We're seeing 10 times as many people use daily now than we saw in 1992. That's a massive number. What implications does that have for people with anxiety and depression? it concerns me that we are not being cautious enough. We are too easy to accept the claims of the marijuana industry instead of the science. And for the science, we need to hear from people like Rajiv and others to tell us what the science is saying about the promising parts of marijuana that could be helpful in very specific settings, but also the parts we need to be extremely concerned about. So thank you very much for having me.
Thank you, Kevin. That was great, and that was a great overview of what I am going to be talking about. Don't know if you can see my slide okay. Okay, so again, I think this is a very important topic and important and controversial, which is why I was very happy when ADAA agreed to put something together for us. I'm going to focus a little bit about the science. Kevin's covered much of the medical marijuana laws, and some of the confusion may stem from what we know of the science. And so I'm going to discuss that with respect to anxiety and depressive disorders. So by way of disclosures, I don't have any relevant financial conflicts of interest. I do have a funded study with NIH to look at the effects of cannabidiol on microglial activation. The compound is we getting it from GW Pharmaceuticals, but there's no financial support there. And I also have research which is funded by the Yale Center for Clinical Investigations. However, the views expressed in this webinar are my own and not of my employer or funding agencies. So I'm just going to give you a brief overview of the cannabis and the endocannabinoid system. We'll discuss a little bit about medical marijuana and cannabidiol for anxiety and depressive disorders, and discuss risks versus benefits, and then a conclusion slide. So, and like Kevin said, what we're talking about when we talk about marijuana is the whole plant. But in terms of what's used medically, usually it is the flowering tops of the unpollinated female plants. And the reason that this portion is used is because the capitate stalk trichromes of the flowering plant is the place that cannabinoids are rich in cannabinoids. So the plant cannabis contains more than 70 different cannabinoids, which are called phytocannabinoids. And the most common ones that we know are delta-9 tetrahydrocannabinol or delta-9 THC, and the other is cannabidiol or CBD. But yeah, as you can see, there's a list of many more different compounds like cannabigerol, cannabichromine, etc. Now, apart from the phytocannabinoids, cannabis also has close to 430 different other components. So there are minor cannabinoids, there are terpenoids, and these are compounds that gives it the characteristic skunk-like smell. And there are compounds called flavonoids, which are also present in cannabis. Now, these compounds also seem to have some effect on the brain because they also bind to certain receptors in the brain, like the GABA-A receptor. They alter GABA levels. They act on the NMDA receptor. They alter glutamate levels, act on the adenosine A2 receptor, and also on the CB2 or the cannabinoid 2 receptor, which I'll come to. And some of these compounds have been shown to have some analgesic properties as well. So the main constituents or phytocannabinoids exert their effect by acting on certain receptors in the brain. The ones seen in humans are the CB1 receptor, which is primarily expressed in the brain, and there's another receptor called the CB2 receptor, which is primarily expressed in immune cells in the periphery, and also immune cells in the brain called microglia. There are also some other receptors like the TRPV1 receptor, and this is the site that capsaicin acts on, which is responsible for some of the analgesic properties of cannabinoids. And there's the G-coupled protein called GPR55, which is thought to be relevant for some of the anti-epileptic effects of cannabidiol. Now, this is an image of the brain of a rat, which shows the CB1 receptor. And as you can see, the bright areas are places where the CB1 receptor is most dense. And it's primarily, the distribution is around the cerebellum, the hippocampus, the substantia nigra, the caudate, and the cortex. And these are regions important in things like motor coordination, memory, reward, and just cognition overall. And this is also the case in humans. So this is a study that was done at Yale using a ligand called 11C-OMAR that binds to the CB1 receptor. And it pretty much recapitulates what we see in animals, that the CB1 receptor is present in high density in brain areas concerned with memory, cognition, motor coordination, and reward. So for a long time, people wondered, why does the brain have a receptor for a compound found in plants? And of course, the joke at the time was that maybe God put it there so people can smoke cannabis. Well, that didn't really turn out to be true. I mean, there seemed to be a more logical explanation, and that was that we as humans produce compounds that bind to these receptors, and these are called the endocannabinoids. The most common endocannabinoids that you see discussed are anandamide, which is derived from the Sanskrit word anand, which means bliss, and 2-AG or 2-arachidonyl glycerol. But there are other endocannabinoids as well, such as oleamide, which is thought to have some effects on sleep, and virodamide, which has effects that are the opposite of anandamide. So coming to the endocannabinoid system is very unique in many ways. One is that it's a lipid neurotransmitter. While most neurotransmitters are monoamines, endocannabinoids are lipids. They are synthesized on demand, which means that they're not stored in vesicles like other neurotransmitters. There's a property called retrograde neurotransmission that I'll come to in the next slide. Endocannabinoids are thought to have biphasic effects, which means that they may have different effects at different doses. For example, a low dose may be anxiolytic or reduce anxiety, while a high dose may be anxiogenic and increase anxiety. Another property which has been noticed in animal models is the concept of entourage effects, which means that sometimes endocannabinoids can augment the effects of each other while they themselves have a lower effect. And another property is functional redundancy. That is, in some ways, anandamide and 2-AG can compensate for the effects of each other. Now, this is just a schematic of retrograde neurotransmission, and this is just to illustrate the importance of this system. It's a busy slide, but just to walk you through it, on top, what you see in pink is the presynaptic terminal. The space between them is the synaptic cleft, and the blue below is the postsynaptic terminal. And with neurotransmission, what happens is when there's an action potential at the presynaptic terminal, it causes the release of neurotransmitters. And in this case, as you can see in pink, what's depicted is the glutamate neurotransmitter. The transmitter crosses the synaptic cleft and causes depolarization of the postsynaptic membrane. This triggers the synthesis of anandamide and 2-AG. Because they're lipid neurotransmitters, they cross back across the membrane and act on the presynaptic terminal on the CB1 receptor, which then inhibits the release of neurotransmitters. So what's depicted here is what happens with glutamate. So if there's too much of glutamate being released, the endocannabinoids can break the system by acting on the CB1 receptor. But this is also true for GABA, which is an inhibitory neurotransmitter. So as you can imagine, the endocannabinoid system is crucial in maintaining this exquisite balance between excitation and inhibition. And it's not surprising that it supports a lot of the homeostatic mechanisms in the body, including circadian rhythm, sleep, appetite. It's important in neurodevelopment, in embryogenesis, in brain development, in neuronal migration and stress modulation. The CB2 receptor, which is present on immune cells, is also important in the inflammatory processes and in microglia as well, which is thought to be important in a process called pruning that occurs in adolescence. So there's a process by which the brain fine-tunes its neurons, and this occurs during adolescence. And the microglia are known to be important for that. So just to kind of summarize, this tells us that this system has a fairly complex pharmacology that they're dealing with. We know that delta 9 THC acts as a partial agonist to the CB1 and CB2 receptor, but the effects of cannabidiol are not all that clear. There's some evidence that it may act as a negative allosteric modulator of CB1. There was some initial discussion that maybe it acts as a FAAH inhibitor, which is an enzyme called fatty acid amide hydrolase. But it's also an inhibitor of cytochrome enzymes, CYP2D6 and 3A4, which are important in the metabolism of other drugs, and that would be important in looking at drug interactions. What's not clear is if there's any entourage effects of terpenoids. So people say that maybe you need the whole plant, and the effects are different than just THC or cannabidiol. But the entourage effects of terpenoids has not been shown in humans, as far as I know. So the one thing to emphasize is that the phytocannabinoids is not the same as endocannabinoids. The effects of phytocannabinoids are different in many ways. One is that the effects are non-physiological, so they're not synthesized on demand. So it's not when the postsynaptic membrane or the release of glutamate that the system is activated. It's when someone smokes cannabis. It's not degraded readily. THC binds with about a 10-fold greater affinity to the CB1 receptor than the endocannabinoids. And the duration of action is prolonged as well. And more importantly, the binding leads to a downregulation of CB1. And so in a sense, people have to smoke more to get the same kind of effect as they used to before. So moving on to what is the evidence that we have for the use of medical marijuana and cannabidiol for anxiety and depressive disorders. Now, this is a slide which, again, this is something that Kevin was talking about, is how different states across the US have approved different conditions for medical marijuana. And what you can see is that it's not uniform across states. That's the first thing. I've also highlighted in red conditions that may be considered psychiatric, and these include post-concussive syndrome or TBI, post-traumatic stress disorder, anxiety, refractory generalized anxiety disorder, anorexia, agitation and Alzheimer's disease, Tourette syndrome, autism, and different states have, to different degrees, approved some of these conditions. There are some states in which any condition which causes severe disability may be approved per their medical board as well. So this brings up a lot of challenges which physicians and colleagues of mine always face, is that one is, how do you decide if there's adequate evidence for an indication? And how do you weigh the risks versus benefits? And the other concern is that there are so many different products on the market with high THC, high CBD, CBD oil. There's an entire different vernacular that physicians have to learn to kind of figure out what people are using. And of course, there are the legal challenges that come with a Schedule 1 substance. So this is so what do clinicians need to know? We put together a commentary in the Journal of Clinical Psychiatry last year, kind of going over some of these aspects. One is there are more than 2,500 different strains of medical marijuana. There are some which are considered CBD strains. There are others which are just THC strains. There are high THC strains with more than 20% of THC. And this is a lot higher than what used to be in just street marijuana, used to be in the 70s or 80s, was about 5%. So this is a lot higher in concentration. There are strains which are high CBD, but even though they're called high CBD, they have just more than 5% of CBD. One point to remember is that all CBD that's extracted from hemp usually contains some THC or THCA. And this is a point that sometimes is lost, that people say, oh, I'm just smoking CBD strains. But even if it's a high THC strain, if it's extracted for hemp, it usually contains some THC or THCA. Most of these compounds come with a labeling, and sometimes, what's important is to figure out what's the total THC content that's present in the product. THC has an analog called THCA, which is tetrahydrocannabinolic acid, and tetrahydrocannabinolic acid is converted to THC on combustion. So what's important is to factor in the concentration of both of those components. And as Kevin alluded to, there's a discrepancy between the labeling and what's the actual content of THC and CBD. So the FDA has, found that some compounds, some products, which state that they have a high THC content, sometimes do not have any, CBD or THC at all. And again, the other question is also, if you do want to harness the effects of the cannabinoid system, like Kevin was saying, there are already compounds that are available and approved by the FDA, which include dronabinol, nabilone, and Sativex, which is available in Canada. So coming to the evidence for medical marijuana, I mean, there have been two reviews, one which is fairly recent in 2019 by Black et al., which appeared in the Lancet. And we also reviewed this for the Journal of Clinical Psychiatry in 2016. The present level of evidence, and this is a systematic review and meta-analyses, which looked at like 42 studies in depression, which included 31 studies in anxiety, 12 studies in post-traumatic stress disorder. And they concluded that pharmaceutical THC with or without CBD, again, this is not about medical marijuana, but this is the individual components, seem to improve anxiety symptoms in individuals with comorbid medical conditions, primarily those with chronic non-cancer pain and multiple sclerosis. But the review also concluded that the evidence per the grade was very low. And they also noted that there were very few randomized controlled trials of pharmaceutical CBD or medicinal cannabis. And not surprisingly, pharmaceutical THC with or without CBD was also associated with an increased rate of adverse events and increased withdrawal from the study due to adverse events. And this, I think, is going to be a moving target. Like Kevin was saying, as we have more and more studies, it's always going to be important to kind of figure out where is the evidence at today, or in the next few months. And an important way of looking at the evidence and what's something that most groups use is what's called the GRADE, which is the grading for recommendation, assessment, development, and evaluation. Now, the GRADE takes into consideration aspects of the study, which includes the design of the study. Was it conducted? Were there any flaws in the execution of the study? Was blinding adequate? Is it generalizable to the public? What's the effect size that's seen? And they usually, grade studies based on either evidence of having a high degree, a moderate, low, or very low. What's important to recognize is that an observational study with no serious flaws in study quality and well done as well is still considered a low-grade evidence, and that's because of the confounders that may affect how an observational study is interpreted. And to reiterate, the FDA standard is for any pharmaceutical drug that's on the market is to have at least 2 adequately powered randomized controlled trials. So with post-traumatic stress disorder, there are very few prospective studies of cannabinoids. There are no randomized trials as of yet using medical marijuana, though there are some studies that are underway. There are 2 trials with small sample size and a high expectancy response. We reviewed this in our paper in 2016. There's a lot of information, but just to highlight, some of these were, there were 2 studies which used smoked cannabis. They were prospective, open label studies with the small sample sizes, 29, 80 approximately. But they were still conducted in a way which led them to be of very low grade quality. Similarly, there are a few more studies, 2 more prospective studies, and 2 retrospective chart reviews. They're of low quality overall, but there seems to be some consistency in terms of them noticing some improvement in terms of nightmares and sleep quality. Well, but this is the evidence is not consistent throughout, because this is a study that looked at the national PTSD program evaluation with over 47,000 people who had intensive PTSD treatment, and they looked at people who were never users, that's people who've never smoked cannabis, those who stopped using cannabis during treatment, those who continued using cannabis during treatment, and those who started using cannabis during treatment. And they found that the greatest improvement, the greatest change in PTSD was in the group that actually stopped smoking. So those who continued using did not improve as much, and the group that actually stopped smoking cannabis had the greatest improvement with treatment. So the overall evidence for the use of marijuana in PTSD seems like it's very low at the present time. There are retrospective studies that suggest that there may be some improvement in sleep and nightmares, but this warrants further research. Studies also suggest that cannabis use was associated with less symptomatic improvement from treatment, both with medication and psychotherapy. What about other anxiety disorders? There are anecdotal reports of benefits in social anxiety disorder and generalized anxiety disorder, but there are no real randomized controlled treatment trials. There are 2 laboratory studies, and this is one of them, which gave people with social anxiety disorder a single dose of cannabidiol and examined, social anxiety in terms of a public speaking test. And they found some improvements in anxiety, as seen in blue here in the top panel. And so there is some encouraging results, but the sample size again was fairly small, with just 12 subjects in each arm. There's another study from the same group which looked at 20 treatment-naive patients who received 400 milligrams of CBD, and again they noticed a reduction in anxiety on a self-reported measure, and also a reduction in cerebral blood flow in the left hippocampus on SPECT imaging. But again, the sample size is fairly limited. There's some promise, but of course, we do need more studies. What's the impact of cannabis on anxiety disorders in large studies on a systematic review? Found that it is there were like 12 studies of people with PTSD, studies with people with panic disorder, bipolar disorder, and depressive disorder. Across 11 studies, recent cannabis use was actually associated with higher symptom levels over time relative to those who did not use cannabis. And in 10 studies, the cannabis use was associated with less symptomatic improvement with treatment. And this again is consistent with the earlier studies that were seen. So the challenge becomes, how do we balance risks versus benefits? It's also important to recognize that cannabis has, side effects which are fairly pronounced, including tolerance of the loss of efficacy, abuse, dependence, withdrawal syndrome. They can cause short-lived and persistent cognitive deficits, and this is important, especially when it comes to motor coordination, motor vehicle accidents. There are psychiatric outcomes being a risk factor with cannabis use, including psychosis, mania, depression, and importantly, in young people, there is some evidence that it may cause an amotivational state where people drop out of school or college, or there's a decline in scholastic performance. So studies have shown that, at least the SAMHSA numbers, is that approximately 1 in 10 people who use marijuana will become addicted. And if people start using before the age of 18, the rate of addiction rises to 1 in 6. Recent studies suggest that 30% of those who use marijuana may have some form of cannabis use disorder. And people who begin using before the age of 18 are 4 to 7 times more likely to develop a cannabis use disorder. Cannabis withdrawal is an important component of that sometimes overlaps with symptoms of anxiety. And so sometimes it becomes difficult to know if people report that cannabis is the only thing that helps their anxiety. It sometimes is tricky to know if it's because of cannabis withdrawal or is it really treating a underlying anxiety disorder. So this is a study in which 11 cannabis use disorder subjects were abstinent for 4 weeks, and we monitored things like, what are their withdrawal discomfort, irritability, and some of these last for as long as 4 weeks. So things like sleep difficulty, strange dreams, decreased and sometimes nervousness. They seem to last for a long period of time. Now, the effects on cognition, as I mentioned, there's a higher rate of school dropouts. There are epidemiological studies which show a 6 to 8 point lower IQ among those who use cannabis before the age of 18. The effects on motor coordination, reaction time, and driving are important, and the effects on motivation as well. Now, one of the risk factors that we know from epidemiological studies is this risk of psychosis. There's been a modest but consistent association that cannabis use can increase the odds of psychosis at least twofold. There seems to be a dose response. The earlier and more chronic the use, the heighten the risk. And there may be some genetic vulnerabilities to this as well. Now, one of the other important things to consider is the effects of cannabis use on pregnancy. So cannabis use among women in California has doubled between 2009 and 2016. Animal studies suggest that there may be a syndrome similar to fetal alcohol syndrome that occurs with cannabis use as well and results in hyperactivity as well. And this is not surprising given the role that we know of the endocannabinoids in placental function and development of the embryo. Lastly, in terms of motor vehicle accidents, there have been studies which have found that THC was the most commonly found substance in the blood of people who were impaired, fatally injured, or in motor vehicle accidents. Approximately 4 to 14% of drivers tested positive for THC. And in a study of over 3,000 fatally injured drivers in Australia, when THC was present in the blood, the person was more likely to be at fault for the accident. So higher the THC concentration, more likely the driver was to be culpable. So the other considerations in terms of physicians who are treating people for other medical conditions is that CBD also acts on cytochrome P450 enzymes and leads to drug interactions. This is important for antipsychotics, for SSRIs, and also THC may reduce concentrations of risperidone and 9-hydroxyrisperidone. So, an antipsychotic that's used to treat disorders like schizophrenia and bipolar disorder. So the clinical challenges again are, the issues with labeling, the legal challenges that come with Schedule I drugs, figuring out our symptoms due to anxiety or depressive disorders or due to cannabis withdrawal, the risks of worsening mood, anxiety, manic episodes, psychosis, and cardiovascular risks such as MI and tachyarrhythmias. There have been reports of these too with cannabis use. So in conclusion, cannabis contains more than 430 different chemicals. THC is the main psychoactive constituent. The two endocannabinoids, anandamide and 2-AG. And in conclusion, the evidence for the use of medical marijuana and CBD for anxiety and depressive disorders is very low at the present time. Although there may be some promising research which may lead us to better, medications for these disorders. And as Kevin alluded to as well, medical marijuana is a complex issue that requires careful discussion, documentation of risks and benefits when treating patients. So that's in a sense, what I wanted to talk to you about today. Thank you.